Welcome to the presentation on post-stroke, end-of-life care. My name is Xu Zhizhen, and I'm happy to present this topic together with Dr. Anke Singh. At the end of this presentation, you will have learned what is palliative care, who delivers palliative care, and how palliative care is delivered in post-stroke patients at the end of life. What is palliative care? Palliative care, as defined by the World Health Organization, is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness. This is through the prevention and relieving of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. Who delivers palliative care? The answer is palliative care should be delivered by all of us. There are two types of palliative care, which is primary and specialist palliative care. Primary palliative care is provided by non-palliative care physicians, nurses, and allied health professionals who offer basic symptom management and determination of goals of care. On the other hand, specialist palliative care is provided by an interdisciplinary specialist palliative care team, which consists of palliative care physicians, palliative care nurses, social workers, physiotherapists, occupational therapists, speech therapists, dietitians, and the champions. Early referral to the specialist palliative care team should be made to manage complex refractory symptoms, to assist with challenging family meetings, and to provide bereavement support for complicated grief. We will now touch on three main principles of palliative care delivery: symptom detection and management, identifying and addressing psychosocial aspects of care, and establishing goals of care. Symptom detection and management. Early recognition of common signs and symptoms of distress is essential. Pain, spasticity, depression, and anxiety are common signs and symptoms seen in post-stroke patients. At the end of life, they may experience other different symptoms, for example, pain, dyspnea, respiratory secretions, agitation, and restlessness. Pain is one of the commonest symptoms in post-stroke patients. However, detection of pain can be challenging as patients are commonly non-communicative. FLAG scale is a validated assessment tool to assess pain in patients who are unable to communicate. The 5 components included in the assessment are face, legs, activity, cry, and consolability. Each component is assigned a score of 0 to 2, with a minimal score of 0 representing no pain, and 10 is the worst pain. Dyspnea is another common symptom in post-stroke patients at the end of life. These are signs to suggest dyspnea or dyspnic behaviors. For example, labored breathing, as evidenced by the use of accessory respiratory muscles, the presence of paradoxical breathing patterns, tachypnea, and restlessness. Now, let's have a look at how these symptoms can be effectively managed. Basic principles of management for end-of-life symptoms include pharmacological and non-pharmacological interventions. Non-pharmacological management of pain includes pressure relief to prevent pressure sores, gentle massage, and passive range of motion exercise. The WHO analgesic ladder can be adopted as a guide to pharmacological management of pain. Do consider use opiates if necessary. Where appropriate, muscle relaxant, for example, baclofen, clonazepam, as well as neuropathic agents such as tricyclics antidepressants, anticonvulsants, and corticosteroids can be considered. Positioning, oxygen therapy, and the use of handheld fan blowing onto the patient's face are useful non-pharmacological management of dyspnea. Use of opiates and benzodiazepines are common pharmacotherapies in management of dyspnea in end-of-life phase. Non-pharmacological management of respiratory secretions includes positioning, such as placing patient in a lateral or semi-fowler position to prevent choking by excessive secretions, gentle chest physio or oral suctioning as tolerated. In patients who are imminently dying, reducing or stopping hydration and nutrition should be considered. Anticholinergics such as hyoscine butylbromide, glycopyrronium, or sublingual atropine drop are commonly used in treatment of respiratory secretions. Regular oral care, which includes oral toilet followed by applying moisturizing mouth gel, is important, as anticholinergics can make the patient's mouth very dry. If pneumonia is the cause of respiratory secretions, time-limited trial of antibiotics can be considered if deemed appropriate. Creating a quiet, well-lit environment and having a familiar care provider are important factors when it comes to management of patients who are restless. Physical restraints are not recommended in management of patients who are restless. It is also important to exclude common and easily managed reversible causes, for example, urinary retention and constipation. Antipsychotics such as haloperidol, as well as benzodiazepines, for example, midazolam infusion, are used as pharmacotherapies in management of agitation and restlessness at end-of-life care.
Dysphagia is common following acute stroke. Tube feeding with supplementary pleasure feeding is a common option for feeding. Artificial nutrition and hydration are considered medical treatments, and it should be discussed with clear goals and objectives and the patient's best interest in mind. Withholding and withdrawing of hydration and nutrition is appropriate if the objectives are not met. Concerns about feeding and hydration following stroke are major sources of distress for families, as provision of food is often seen as an expression of love and care. Recognizing and validating the family's concerns is an important first step in reducing their stress. Highlighting to the family that the patient will not experience hunger or thirst when imminently dying will help reassure the family. It may be necessary to tell the family that continuing hydration and feeding in this state may exacerbate peripheral edema and respiratory secretions. Blood glucose monitoring should also be stopped. Identifying and addressing psychosocial aspect of care. Stroke patients and their family members are generally unprepared for the psychosocial impact of stroke. Depression and anxiety are common psychological symptoms in post-stroke patients. Fatigue, caregiver strain or burnout, anticipatory grief, and complex bereavement are often seen in family members and caregivers. Initiatives such as early involvement of social workers to support patients and their families, antidepressants, and involvement of the pastoral care team to address the patient's and family's spiritual needs may also be considered. Establishing goals of care. Goals of care are healthcare decisions and refer to much more than the patient's resuscitation status. Establishing goals of care includes establishing specific ceilings of treatments as well as the preferred place of care and death. Specific ceiling of treatments can broadly be understood as ICU care, ward-based limited resuscitation, or ward-based full palliation. Ward-based limited resuscitation may sometimes be further subclassified into sealing that could include the administration of inotropes or intravenous fluid bolus or limiting to intravenous treatment. Thus, ward-based limited resuscitation differs from ward-based full palliation, which could be limited to enteral treatment. Needless to say, where possible, goals of care discussion should occur earlier in the disease trajectory and not just at the end of life. As alluded to, establishing specific sealing of treatment should be a shared decision. We propose 3 steps for shared decision-making. First, explore and establish, where possible, the patient's and family's understanding, perceptions and misperceptions of the current condition. Second, explore the patient's personal values and wishes with regards to the end-of-life care preference. This can be understood as with reference to sealing of treatments, as well as the place of care and death. Third, advise on the best anticipated functional status for the patient with and without the treatment. The best anticipated functional status can be understood on 2 counts: communication and function. Thus, advise how well the patient could communicate verbally or using communication aids such as eye gaze devices. Also, advise on how well the patient could physically function or how much assistance would be required for activities of daily living. Thank you for your attention. We would like to reiterate that early recognition and management of distressing symptoms are imperative in enhancing quality of life in post-stroke patients. Do address the patient's and family's psychosocial and spiritual issues. Finally, where possible, establishing goals of care and shared decision-making on specific sealing of treatment should occur earlier in the disease trajectory.